Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse, as well as CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. We would like to thank our following partners for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, who is CLL Society's Executive Vice President and Chief Medical Officer.
Thank you, Robin. I'd like to welcome our audience and speakers to today's events. We are being joined by Dr. Shoham. He's a professor of clinical medicine at Johns Hopkins University School of Medicine, and his area of expertise is in infections, especially those in the immunocompromised. Afterwards, our own Robin Brumble, an RN, will walk us through the CLL Society's COVID-19 action plan, which has been updated, and share with you the importance of being prepared. Our speakers are going to be sharing some brief PowerPoint presentations, but the majority of today's event is going to be dedicated to your questions. So please use the Q&A box to send in your questions to our speakers. That's what's going to take up most of the time for this meeting. I want to let you know that this webinar will be typing in a few responses to your questions, as well as answering them live. If you don't want your name associated with your question, please check the box that says send anonymously. So now it's my pleasure to welcome Dr. Shoham.
Hi, everybody. My name is Shmuel Shoham, and I am professor of medicine at Johns Hopkins University School of Medicine. Today, I'm going to talk about COVID-19 treatment considerations, and the focus of my clinical practice is in patients that have had transplantation or patients that have leukemia, lymphoma. I'm going to make it focused in the direction of patients that are with leukemia. Here are my disclosures, and I've done quite a bit of work with CCP, which is COVID convalescent plasma, and that study was funded primarily by the Department of Defense and also by Bloomberg Philanthropies, the state of Maryland, and the other organizations that you see listed. I also do other research, mostly involving fungal infections, and you can see the other funding that's listed. And I have done quite a bit of consulting for various companies and various studies, and those are listed as well. I'm going to start with a case, and this is a 56-year-old woman with a history of CLL and low immunoglobulin levels. Despite multiple COVID-19 vaccine injections, she's failed to develop a good antibody response. She's now in the midst of her third COVID-19 related hospitalization. The first was 3 months previously, and it was treated with 5 days of the antiviral remdesivir. She also received steroids and was discharged on home oxygen. She's not normally on oxygen. Then she was admitted the second time, and that was for an episode of presumed bacterial pneumonia. And she had not felt well in months and is now back in the hospital a third time with mildly low oxygen level, fever to 101.5 Fahrenheit, SARS-CoV-2 PCR, that's the COVID test, positive again, and a cycle threshold of 17. And the cycle threshold is a way of measuring how much virus the patient has. And the lower the cycle threshold, it means that there's a higher amount of virus. So A cycle threshold of 17 actually means that there is a tremendous amount of virus in her nose and presumably in her respiratory tract as well. Just for comparison, somebody with a cycle threshold of, say, 35 or 40 has so little virus in them that the test is probably a false positive or picking up virus that is no longer infectious. So let's go back to what is special about this particular woman. So this study looked at the risks for poor COVID-19 outcomes in people with cancer. And by poor outcomes, it meant that they either had severe disease, bad enough to end them in, for them to be in the hospital or worse, and then even mortality. And the numbers that you can see, and I'm going to circle this with my cursor, and that the big arrows point to, is if somebody has a hematological malignancy, then 1.70 is their odds ratio. And typically, for comparison, 1 is an odds ratio of whatever it is that you're comparing to. And in this particular case, it was healthy people. And 1.70 means that they almost have twice the risk of ending up in the hospital or worse with COVID. In terms of people that have a cancer that's getting worse, active and progressing, then the risk of a bad outcome is twice what it is in the general population. And then when you look at mortality, again, higher risk, almost 3 times of having mortality 30 days into the infection, or having, or if this is somebody with an active and progressing cancer, and if somebody has a hematological malignancy, it's still high, 1.44 times what one would see in the normal population. And then if you focus in on people with B lymphoid malignancies, lymphomas and leukemias, including people with CLL, patients that are recently treated for B lymphoid malignancies have a significantly higher risk of having a bad outcome, such as hospitalization or death. And again, pointing toward the importance of not just having a lymphoid malignancy like CLL in terms of increasing the risk, but it's actually the people that are actively being treated that have the higher risks. Now, in terms of a response to a vaccine, you remember in the case I mentioned that she had been vaccinated but didn't have a really good response. So you remember that an odds ratio, or in this case, a relative risk of 1, means what it is that you're comparing to. And that would be the general population. So if somebody has organ transplantation, their chance of having a response to the vaccine is significantly lower, 0.39 as opposed to 1, compared to the regular population. Hematological malignancy is a little bit better than organ transplantation, but still significantly reduced. And then people with immune disease, solid cancers, and then HIV, you can see that they have better and better response to the vaccine. So I would say that there's a 63% chance of responding to the vaccine compared to a person who does not have hematological malignancies and otherwise healthy. So reduced risk of reduced rate of response to the vaccine. So our patient is one that we described, one that is in the group that did not respond to the vaccine, and also in the group that has had COVID severe enough to end up in the hospital. So what is immunization for the immune compromised? And this is from the CDC. If you get this, then you have the best chance of having a good vaccine response. But again, not everybody that has gets the vaccine that is immune compromised has the response. But what does it mean? So completed the primary series, that's 3 mRNA vaccines, whether it's the Moderna or the Pfizer, or 1 Johnson & Johnson vaccine and 1 of the mRNA vaccine, Pfizer or Moderna, or 2 of the Novavax. So the vast majority of people that we see at our institution have had the 3 mRNA vaccines as their primary series, but these other mix and match possibilities are also the primary series. Now, once somebody's had their primary series, they're not done. So they need to have a first booster, and if they're immune compromised, a second booster. And the first booster is given 3 months after the completion of the primary series. And then the second booster is given 3 months after the first booster. So if you've had the 3 vaccines for the primary booster, if you're doing the mRNA vaccines or the other combinations listed, and then on top of that, a booster, and on top of that, a second booster. So 5 vaccines in total if you've been doing the mRNA. And the site that describes exactly what it is in a very patient-friendly way is listed here. Okay, this is a very sciencey looking slide, but I'll walk through the points that I wanted to make. So monoclonal antibodies have been a fantastic therapy for COVID. However, the problem is that as the virus mutates, some of the monoclonal antibodies lose their punch. And bamlanivimab is one of the earlier ones, and in the slides that I'm showing here, the lower the numbers, the better the response. And bamlanivimab, as you can see here at the bottom, against BA4 and BA5, which is what we now have as the vast majority of the viruses in the US, almost 100% are BA4 and BA5, does not work. It doesn't get the virus concentration down low where you'd like to be. Bebtelovimab is still active. It does get the virus concentration down low. This percent infectivity means very low concentration. So you start the drug and then it knocks the virus out. Casirivimab, which is a part of what was part of Regeneron, doesn't work anymore. Sotrovimab, which we used to give, works just kind of a little, but not really all that well. So for the treatment monoclonal antibodies, the only one that's really active against the viruses that we have now in the US is bebtelovimab. And I recommend that for my patients who come down with COVID as one of the treatment options. Another treatment option is Paxlovid, the oral medication that if somebody doesn't have a drug-drug interaction, they can use that one, and that one, the viruses are fully sensitive to that. There is another monoclonal antibody that is used for prophylaxis, and that's Evusheld. And Evusheld is a combination of 2 different monoclonal antibodies. One is silgavimab, and one is tixaglimab. And as you can see, silgavimab, because the numbers are pretty low, still has activity against BA4 and BA5, although not as good as, say, bebtelovimab. So it's only partially active. And the other part of Evusheld, the tixaglimab, has very little activity. So Evusheld is still giving you a little bit of protection, or maybe a decent amount of protection against BA4 and BA5, but not nearly where we would like it to be. So I'm still recommending for people to get that as pre-exposure prophylaxis before they've had an exposure to somebody with COVID, as a way of protecting them, but with the understanding that it's less effective than it had been against prior variants that were circulating of the virus. So putting that all together, antiviral options authorized for treatment of COVID. We have bebtelovimab, the monoclonal antibody. It's given by IV. It's for outpatient or for inpatient if the reason for admission is not COVID. If somebody has, say, CLL that's acting up and they need to come into the hospital for a transfusion or for some other reason that's related to the CLL, and they're incidentally found to have COVID, or they have COVID that, had they not been in the hospital for this other reason, would be able to be treated as an outpatient, then they can get bebtelovimab. On the other hand, if the reason that they're admitted is because of COVID, if the COVID is severe enough to end them in the hospital in and of itself, then bebtelovimab is probably not going to be effective, and it's too late to be used, and it's not FDA authorized for that. Nirmatrelvir and ritonavir, that's Paxlovid, that's given by mouth. It's for outpatients only, and it has lots of drug interactions with the ritonavir part. So a physician and a pharmacist must look at the entire medication list to make sure that it's okay. Molnupiravir is another oral medication. It's probably not as effective as the other therapies that are out there, and it can cause fetal harm, so not for pregnant women, and it's only for outpatient. Remdesivir is a drug that's approved for outpatient and inpatient, and it's by IV. Convalescent plasma, which I'll talk about a little bit more, is approved for immune-compromised patients, such as CLL patients, for inpatient and outpatients. And Evusheld, as I mentioned, is that monoclonal antibody combination that's for pre-exposure prophylaxis, still effective, but again, with the circulating viruses that we have, not as effective as we would like. This is how to give Evusheld according to the FDA. And a little bit about convalescent plasma. So convalescent plasma is blood, the plasma part of blood from people that have had the infection, have cleared the infection, and have now convalesced, have gotten better. And ideally, the convalescent plasma that's collected from people is from people that have both had the vaccine and the infection, because they have the highest antibody levels. And in this study that was done pretty early on during the time of the pandemic, people that got convalescent plasma who were hospitalized, who were hematological malignancy, patients with hematological malignancies, their overall survival probability was better if they got convalescent plasma than if they didn't. And this one here is the curve that shows better survival if people got the convalescent plasma. And why was it effective? It's probably because people with hematological malignancies are not as good at making their own antibodies to fight the COVID, so that giving them antibodies from people that have already recovered from it is effective. Several other studies have been done in people that have B cell problems, either because of their malignancy, such as CLL, or because of its therapy, which sometimes depletes or removes B cells in the body, such as treatments with drugs like rituximab and other similar drugs. And these are people that had COVID, were tested for COVID antibody and were negative, so they were not making antibody, and the treatment was to give them convalescent plasma, the blood component from people that have recovered from COVID that had a high level of antibody against COVID. Neutralizing antibody is what it's called, and 84% of those people recovered. Similar study, you had 8 patients, also B cell depleted, had a prolonged disease course, like the lady that I mentioned in the case description, where they were sort of caught and could not get over COVID. Their body just couldn't quite clear it. And when convalescent plasma was added to their standard medical therapy, then the patients showed remarkable clinical and laboratory improvement. Now, it's not magic. The reason that they got better is that they had a deficiency, and that deficiency was that they, unlike other people, could not make antibodies against COVID, and antibodies are important for clearing the body of COVID. And by giving them antibodies made by other people, then it was effective. And with that, I'll finish and take your questions.
Thank you, Dr. Shoham, for that excellent presentation. We now welcome Robin Brumble. Robin is the Director of Scientific Affairs and Research for the CLL Society, and we are very lucky to have our own registered nurse as part of our team.
Thank you, Brian. Hello, everyone. My name is Robin Brumble, and I'm going to review CLL Society's COVID-19 action plan with you today. The reason behind why CLL Society put together a COVID-19 action plan is because those in our community were reaching out to CLL Society after having either known exposure to COVID-19 or receiving a positive test result, and many weren't quite sure what to do. The COVID-19 action plan is comprised of several checklists that you can begin to fill out right now before COVID-19 impacts your home. If you have not already, we highly recommend that you spend some time reading through the directions and filling in the blanks as they apply to your unique situation. Then print out the completed checklist and keep your personalized plan in an accessible place so that you can easily refer back to it when you need to. I'm going to very briefly go through the 5 pieces of the plan and provide some screenshots. The first 2 pieces of the plan include reading through the detailed step-by-step directions and then filling out the corresponding checklist that is called Complete Prior to Exposure. The intent of these first 2 documents is to guide you through what exactly you need to do far in advance of getting COVID-19. And I do think it's important to note here that these 2 specific documents have been updated several times since the plan was originally created based on the most recent recommendations. So please make sure that you have the most recent version available to you. Some important things that these first 2 checklists will walk you through include looking up important phone numbers that you will need to call ahead of time, keeping a suggested list of supplies readily available, such as a pulse oximeter and thermometer, for example, and how to find where exactly you will go to receive things such as Evusheld, testing, oral antiviral therapy, and monoclonal antibody treatment when needed. The next 2 checklists include what to do if you have known exposure to COVID-19 or a positive test result. These 2 documents will guide you through exactly when you should obtain a COVID-19 test after known exposure, how long to monitor for symptoms after exposure, and perhaps most importantly, how to adequately quarantine. If you aren't quite sure what steps you should take to try to keep from getting COVID-19 from someone else in your home who has already tested positive, then please read through this checklist so you can be well informed and prepared. The next checklist I will be sharing with you is perhaps the most important. It tells you exactly what things to do after testing positive for COVID-19. This checklist reminds you of the steps that you should take early on, which is key. One of these steps is to call your healthcare provider immediately to discuss how you can receive oral antiviral therapy or monoclonal antibody treatment as soon as possible. It will also prompt you to keep a log of your vital signs and symptoms, what to remember to do should you need to seek emergency medical care, and steps to take after your illness has run its course. You can find all these checklists on our website at cllsociety.org. As you can see in the screenshot of our website, there is a COVID-19 button located near the top of our homepage on the menu bar. If you click on that button from the homepage, it will then take you to our dedicated COVID-19 information page. Then in the middle of our COVID-19 webpage, you will see an option that says COVID-19 Action Plan. After clicking on the action plan, you will be directed to the page where you will find all the checklists that I have reviewed with you today. Please remember the COVID-19 action plan is there for you on our website whenever you need it, but we highly recommend you access it ahead of time before you're exposed or start to feel ill. Doing so will help you have peace of mind knowing exactly who to call, what supplies to have, and what to do in the moment. After you complete your plan, we suggest you keep your checklists in a folder and place them in an accessible place. And it's also very important to discuss your plan with other members of your household so that they too can know what to expect. And please remember, if you have known exposure, any symptoms, or a positive test result, act fast. Even if you do not yet have symptoms, call your health provider right away, because obtaining early COVID-19 treatments, such as the oral antiviral Paxlovid or IV monoclonal antibodies, are very important for achieving your best outcome possible. This is especially true for those with CLL and SLL. Thank you, and please stay safe.
Before we begin our question and answer, I do have some poll questions that really help us if you could complete those for us. And I'll share the answers with you after. So I'll read through them here with you. Since the start of the COVID-19 pandemic, which of the following ways, if any, has living with a blood cancer most impacted your mental health? Please select all that apply. Let's go to question 2. How strongly do you agree or disagree with the following statement? I'm less vulnerable to the negative impacts of COVID-19 today as I was before vaccines, pre-exposure prophylaxis that we just learned about, and the treatments that are now available. Question 3, how strongly do you agree or disagree with the following statement? I feel comfortable attending an in-person educational event that takes place indoors. And you can tell that the CLL Society is very interested in your answer as we look at what our future plans are. So this would be an indoor educational event. Question 4, have you obtained Evusheld, the only authorized long-acting monoclonal antibody that can prevent COVID-19 infections before exposure, pre-exposure prophylaxis? And the last question, what part of your experience with CLL, SLL, if any, have you found to be the most emotionally challenging? And again, you can select all that is apply here. So let's take a look here. Very interesting answers. In question number 1, you can see 3 out of 4 people had a loss of things I used to enjoy. And that would certainly apply to myself. And I think the next highest number, not surprising, was this sense of isolation. Only 12% said it has not impacted them emotionally. Feeling misunderstood, 1 out of 2 feel misunderstood by others. Feeling of sadness, very significant. Stress, more than half. Feelings of restlessness in about 1/4. So very significant numbers. How strongly do you agree or disagree with the following statements? I'm less vulnerable. So if we put those together, we see only about 60% of people agree that they feel less vulnerable. People are still feeling significantly vulnerable. Though only 5% strongly disagree, there's not a great enthusiasm for feeling like it's safe to get back into the water here. How strongly do you feel about attending an educational event? And it looks like people aren't ready for that, with 3 out of 4 essentially saying not ready, I agree, I disagree, or disagree. And have you been able to receive the Evusheld? Those numbers are much better than they've been in past surveys. So 2 out of 3 of you have been able to reach that. And how about what's the emotional part of your journey? Not a specific question about COVID. And that is this is, I think, a very interesting, that the initial diagnosis was the most commonly chosen as emotionally impactful. I do find the preparation for appointments and care myself, and so do a quarter of you, more than a quarter of you, find that is very tough. Talking to my children, my family about my diagnosis has never been easy. Work challenge is not as much of an issue, but managing stress for 4 out of 10. Costs, interesting here. That's much less of an issue than I might have expected. Side effects, a significant issue. And good for that 1 out of 20 there, for which there is really no emotional impact. So good for that. Thank you. And for that survey, we deeply appreciate your appreciation. We're going to welcome Dr. Shmuel Shoham back to help answer your questions. We're going to try to get to all the questions, but I'm going to tell you in advance, even though we've scheduled about an hour for it, we have well over 100 questions. And if we don't get to your question for any reason, please email it to us at Ask the Expert, the email address, after this event, and we'll try to share them that way. So I'm going to start with the people who sent in their questions in advance, and I'll give you a heads up that in the future you can do that. And that increases the likelihood of getting your questions answered. So just a general question, and thank you for that very clear presentation. Dr. Shoham, what does it mean to be immunocompromised, and what does that specifically mean for a CLL patient? How are CLL patients immunocompromised?
Sure. So immunocompromised means that the body's natural immunity is not working as well as a person whose immunity is working well. And for people with CLL, there's several main things that can make them immune compromised. One is that the disease itself affects the lymphocytes, and lymphocytes are important in protecting the body against a variety of infections. Probably the most important of them are viral infections, including SARS-CoV, and fungal infections. So that's one issue. The next thing is the therapy for CLL. Now, not everybody needs therapy at all times, but the therapy can have collateral damage in that it can impact both the bad cells, the CLL cells that the therapy is meant to impact, but it can also cause damage to some of the other parts of the immune system, and that in and of itself can increase the risk for infections. And then the third and fourth parts are more general things having to do with being a patient. So people that have CLL may have more interactions with the with medical services, and therefore might have a higher chance of coming in contact with people that have other infections that can be transmitted to them, and also often have medical devices that are used for treatment of the CLL, such as central lines and ports, and that in and of itself can also increase the risk for infection. So all those things together join together to make a person with CLL immune compromised.
And let me add this, and if you could comment on that, but we know CLL is a cancer of the immune system and of the B cell specifically, and there's data clear that you shared that we're not that good at making antibodies, especially for in treatment. But it seems that also our T cells, which are the cellular part of the immune system and the longer acting, may also be less functional. Is that a correct understanding?
I think that's correct. And that can both be as a part of the disease, and then also some of the therapies can have unintentional T cell activity in that they're really going after the rogue B cells, but they're as collateral damage hitting some of the T cells as well.
And let me push on this because there's a number of questions that are related to this that came in later. How important are these antibody levels? Is there a level that correlates with protection? What's the difference between seroconversion and protection? And is a level, one level, let's say you get a high level as a CLL patient, let's say you get over 25,000, is that the same as an immunocompetent patient who gets that same level?
Sure. So
a bunch of questions there. Yeah.
Sure. So, and we're talking about antibody levels against COVID, not
Right.
just total antibody.
Right.
Sure. So, so if somebody has the infection or the vaccine, or both the infection and the vaccine, then they can have antibodies against the virus. And typically, if somebody has above a certain number of antibodies, then they're considered to be more protected than if somebody doesn't have antibodies at all, or has lower antibodies. We don't exactly know what that number is. And the tests that are done have variability, so that you can get a test done at, say, Quest, and another test done at LabCorp, and a third done at Santa Clara Medical Center. And they can all come back with numbers, but we don't exactly know how interoperable those numbers are. But that having been said, I would say having a higher number is probably better than having a lower number. Or no number at all. However, that's only part of the story, in that the way to fight SARS-CoV includes both B cells and T cells, and B cells are the ones that make antibodies, so that's a way of measuring how much the response is. But we don't have great ways of measuring how strong your T cell response is to the virus. So it could be that somebody has the vaccine, gets their antibodies measured, their antibodies are not produced or very low, but they still have some protection because their T cells are working. Conversely, somebody can get a good antibody level in the bloodstream, but if their T cells aren't working, that can give a false sense of security.
So let me ask you the follow-up question that we received in several different ways is, should I bother to get my antibodies tested? I mean, you can, with LabCorp, you can spend $6 without a physician's order and get a level of your SARS-CoV against the spike protein antibodies done. So should patients be doing this? Should they ask their doctors to order these tests? Are you advising people to do that?
Sure. So I think every time that I order a test, or that somebody orders a test for themselves, the question that should come up with, is there something actionable that can be done with that result? Sort of begin with the end in mind. So if I get if I order an antibody level on myself, for example, or somebody else, and that antibody level comes back at high, is that going to change my behavior? Am I going to go to that bar mitzvah or to that church service that I wasn't going to go to before? And that's a little bit of a personal question, because what I would advise people is probably having high antibody is good, but I don't know how protected you are, so that I would make the decision as to whether to go to that bar mitzvah or to the church service based on other factors than just the antibody. Now, maybe sort of looking at it as a whole painting, you can say, okay, there's not a lot of virus in my community. This is my daughter who's getting married. I'm going to wear a mask. Most people there, or maybe all people there, are going to wear a mask. They're going to be vaccinated. And if I get that antibody that comes back high, I'm going to be feeling even more confident. then yeah. But I would say on the other extreme is I wouldn't get the antibody, comes back positive, and then it's like, okay, I'm going to go out clubbing in a city that has lots of viral transmission.
All right. Yes, begin with the end in mind. Let me ask you a difficult question here. This is the second question we received actually early in the pandemic. And the CLL Society was very frank about this. The mortality numbers were terrible in a paper out of Europe, a paper out of the US, with about 30% mortality rate for CLL patients when they came down with COVID. Can you bring us up to date now with the new therapies we have and with the new Omicron maybe being a little bit milder, a little less, more upper respiratory than lower respiratory? Are we still looking at those horrible mortality numbers?
No. So, I mean, we could just look at our it's what's happened recently, and when we got word that the president and his wife and maybe some Supreme Court justices who aren't that young all had COVID, I don't think that we all said, "Wow, this is going to change history. They're going to likely end up in the hospital or die." We said, "Okay, this is 2020. They've been vaccinated. There's Paxlovid, there's monoclonals. They can get remdesivir if in their hospital. If their immune system goes out of control, there's therapies for that." It's not as though back in 2020 when, as a candidate, Joe Biden was in the basement hiding so that he wouldn't get COVID and potentially die. So it's a different world altogether. Now, for CLL patients, it's still a different world in that that I'm in the hospital all the time. And it's very rare for me to see a CLL patient or a patient like that in the ICU dying of COVID in 2022. What we sometimes see is people do end up in the hospital. And what I'm seeing more and more is that they end up in the hospital for something else and are discovered to have COVID sort of as an incidental thing. And I think what's happening is that one is there's probably enough COVID in the community that because we're doing a lot of testing, we're finding them. But also I think people are having COVID. It's fairly mild, but it's enough to throw their body off so that their body's balance is out of balance. And then they end up in the hospital with something else that because their body just wasn't operating well. So they might end up in the hospital with chest pain from a heart attack, or they might end up in the hospital with heart failure or with kidney disease, or sometimes with an infection. But so it's not that they're in the hospital dying of COVID, but the COVID might have been sort of like that domino, the first domino that fell, and then things got out of balance for them. In particular, and you look at people with CLL and people with other chronic conditions that are doing very well, but if you scratch the surface, their body is working double time to keep things in balance, so that having that insult to the body in terms of COVID might be enough to throw them off balance, and then a series of things happen, and before they know it, they're in the hospital.
So let me ask you if you've gotten COVID, and from what I understand, a large percentage with Omicron are asymptomatic. So people, it's not like you stay away from the person who's coughing and sneezing. It may be somebody who looks completely healthy that you walk by or whatnot. You've tested positive for COVID. You've got COVID. How long after COVID-19 can a patient? First question is, how long can they transmit it if it's a CLL patient? Isn't that different than what the CDC guidelines is? And second question is, when can you get it again? If you've gotten it, are you protected for a while? Is that your get out of jail free pass? I got COVID. Now I can go visit the grandkids. Now I can go to a ball game. I can go to a symphony. So how well protected are you after the infection? And how long are you a risk if you are immunocompromised?
So the first step is, if somebody has COVID, is they should contact their clinician. So because I think anybody with CLL who has COVID should get treatment. And if they're able to get a drug like Paxlovid, it does have some drug interactions, but if that's been reviewed and they can get it, they should get it.
So let me stop you there. I agree with that, but we're hearing from patients that their docs say, well, you're asymptomatic, you just got a sniffly nose, sore throat, cough, you don't qualify. But what I'm hearing as an infectious disease specialist, you're not going to take that chance. Is that the where you come down on this?
So if they're truly 100% asymptomatic, not even like a whiff of a sore throat, then that doctor may be correct. Although I would say that for a CLL patient, although the authorization is for symptomatic people, for a CLL patient, I would still try to do it. I'm not recommending anybody go against what the FDA is authorizing, but I would say even if there's a little tiny bit of symptom, I'd go for it, because people that don't have CLL, they have the immune system, which is doing 95% of the work, plus the virus, the antiviral on there. If somebody has CLL, the immune system is hampered. It's not that their immune system isn't working at all, but it's just not as effective. So I think that that even the slightest bit of symptom, I would give it. The thing that's tricky about COVID is well, two things are really tricky about it. One is that about 50% of transmission is from somebody who's asymptomatic. You shed virus and you transmit virus before having symptoms. So being next to somebody at the symphony who's completely asymptomatic, or somebody at work, that person could have COVID and could transmit it to you. But then the other thing that's really tricky about it is that there is a window that closes for effective therapy. So typically we say, okay, I'm not feeling so well, let me see how it goes, and I'm getting worse. Okay, now I go to the doctor. But with COVID, there's the viral phase, the phase where the antivirals make the impact, and then there's the immune phase where the disease is now driven by an overexuberant immune response to the virus, at which point antivirals can still help a CLL patient, but the window of opportunity has sort of closed for the best response to the antiviral. So what happens is, if you go to your doctor or you call your doctor and you say, I got the sniffles, I got COVID, I have CLL, and your doctor is telling you, no, let's keep waiting until you get worse, the doctor is wrong, basically. And because they may be waiting until the window of opportunity is closed, and then the antivirals will not be as effective, and the person can get sick and end up in the hospital. So early treatment is important, and early treatment means when the symptoms are really mild.
All right, so let's follow up with those questions. How long is a CLL patient with COVID contagious?
Yeah.
What's the role of testing? When can, your partner has COVID, they've got CLL, when can their wife or husband, sleep in the same bedroom with them again? Yeah.
Sure. So for an immune competent person, somebody whose immune system is fine, probably within about 5 days to 10 days of after they've started having their first symptoms, 10 days to be like super cautious, but 5 days is probably enough. Then they're not as, they're probably not contagious anymore. However, somebody who's immune compromised, they can still be contagious. They can still have a high viral load in their sinuses and respiratory tract, and that can go on sometimes for most people, that can go on for a couple weeks to 3 weeks. But there are people, like the person that was presented in the case, where it can go on for months, and they can continue being contagious for months. And so it's hard to make a blanket statement. Generally, we say at about 3 weeks after the onset of symptoms, providing that the symptoms have resolved in an immunocompromised person, that's how long that they're still contagious. Now, some people are doing—
So 3 weeks, that's much longer than we've heard before, I think. Yeah.
Yeah. That having been said, some people are doing antigen testing, and they want to see when the antigen turns negative. And
when you say antigen testing, you're you're referring to the home test or the
The home
PCR?
test. Yeah, the home test. Sorry about that.
Okay.
Yeah. The ones that so people are doing the home test, and then when the home test turns negative, that's sort of of an indicator that they're no longer having a high amount of virus in their nose, and therefore are less or not contagious at all. The science behind it is good but not great, so it's it, I don't think I gave you a really good, strong, solid
No,
answer.
and we're, in on honesty, a lot of this we're making up as we go along, and we're much better now at understanding it. But COVID has been tricky, and we've gotten some of it wrong at the beginning, and we're getting better at it. But yeah, I think erring on the side of being careful is the right answer. Talk to me about, if I've gotten a COVID infection, am I protected? Is this my window? I've got it. I just did the nasal swabs. It's negative. It's 3 weeks out. There's a concert that I want to go to. There's a family wedding. There's something that I want to go to. Do I have the golden ticket right now because I just got over COVID?
So people that have been vaccinated and have gotten over COVID, in whatever direction it is, have extraordinarily high antibody levels. Now, that's true for non-immune compromised people, and with CLL people, it's going to be less so. But I would say that this period right after you got over the infection is probably your best period. When will you be infected again? Hopefully never, but could be within several weeks to months. So it does happen. So I would say that there is no golden ticket, but maybe sort of a gold-plated ticket.
And I would add, it's also the variant of concern. If you got BA2, you have no protection against BA4 if that's the dominant strain right now. So if what's changed in your community, I've heard of people that are immunocompetent having COVID within 4 weeks of each other, but it's a different variant. So I think that's part of this calculus too. Yeah. So talk to us about Evusheld. What are the side effects? What are the downsides? And what do you see as the benefit of Evusheld?
Sure. So Evusheld is 2 monoclonal antibodies, and unfortunately needs to be given as a shot in the tushy. So that's not ideal, but it's doable. They're long-acting antibodies. They last for about 6 months. So if somebody got their shot 6 months ago, now is the time to get another shot. It's as some of the slides that I showed, it's very active against the viruses that we used to have, but the viruses that we now have, it's only mildly active against those. Now, I would say mildly active is better than not active, and so I still recommend for people to get it and to get the refresher if they last got it 6 months ago. There is a vaccine that's coming along that's supposed to be a better vaccine than the one that we've had so far. The people that are eligible for Evusheld have the same problem with the vaccine that they have had all along, and that they may not respond to the vaccine. So for that reason, I would say get the bird in the hand that you have, another Evusheld shot, rather than waiting for when the vaccine will be available and when you'll be able to get it at your pharmacy or from your doctor, and whether it'll kick in and work and all those things. So I still recommend for people to get Evusheld, but I do want people to know it's not going to make your teeth whiter and your clothes cleaner. It is what it is.
And talk to me a little bit about any adverse events or side effects. Are there concerns that you have? Are there patients you say you shouldn't get Evusheld, an immunocompromised patient in front of you?
Yeah, generally people have tolerated it extremely well, except the fact that it's inconvenient to get a shot in the butt. But if somebody's had an allergic reaction to it, then I wouldn't go for the second time, particularly since it's not such a great drug against the currently circulating variants, but it's generally well tolerated, as are all the monoclonals.
Okay. And let me ask you this, and one of the doctors who's a personal friend of mine sent in a note, and we saw from the numbers you've shown that Evushell's efficacy against BA5 was still effective, but less effective. And then there's some concerns about a new variant of BA5 coming along and that it may be even less effective against that. Is there any thought about like how you figure that out? Is there a thought like they already doubled the dose once? Would they be looking? Is there areas? I know docs look a lot at areas under the curve, and are you in that threshold? You're an infectious disease specialist. Can I get enough antibiotic aboard to neutralize the bacteria that I'm trying to get rid of? Mm-hmm. Are there thoughts about this with Evushell? And maybe you could mention a little bit about the high titer convalescent plasma in this setting too.
Sure. So the Evushell, I don't know that increasing the dose further is going to make an impact, and the reason for that is because the efficacy against the new variants is so significantly reduced. It was when it was mildly reduced, you can bump up the dose and then you can kind of overcome that. But against some of the new variants, it's so significantly reduced that I don't know that you're going to be able to get enough product into people to overcome it. You did mention high titer convalescent plasma, and that's a topic that I've been working on for the past few years. And what that is, it's similar to a monoclonal. Monoclonals are antibodies that were made in the lab to go after the virus. Convalescent plasma is just antibodies that were made in people that have had the infection and resolved, convalesced, and then they have antibodies against the virus. And increasingly, we're using sort of a hybrid product, which is antibodies that were made in people that both have had the infection and got the vaccine. They have very high levels of antibodies against COVID. Ideally, they got the infection in the era of Omicron, so that the antibodies that they have are more current against the circulating variants. And ideally, they've gotten multiple doses of the vaccine, so they have high levels of antibody. And if you do that, then when somebody has COVID, then that can be used as a therapy. And again, with the same concept of better to treat them early than to treat them late. Although there is a lot of evidence that even late treatment in immunocompromised people can make a difference, by late being once that they're already in the hospital. Convalescent plasma is an inconvenient therapy because it's a transfusion. Of course, for CLL patients, oftentimes transfusion is not something that is particularly frightening to them because many have had transfusions. It doesn't seem as something that's way out there and complicated, but it still requires more resources than, say, a shot in the butt or even a shot under the skin. However, what's happened is that we used to have the armamentarium of the monoclonal antibodies, and as the viruses have become increasingly resistant to variants, then the monoclonal antibodies may not be there as an available option, and therefore convalescent plasma becomes attractive again because it does maintain efficacy against the variants, because it's whereas a monoclonal is very focused against one part of the virus, the convalescent plasma is against many different parts of the virus. It's polyclonal, so that if the variant has a mutation that makes it resistant to one of the monoclonals, the polyclonal convalescent plasma could still get it.
Simple. I hope this is a simple question. Evushell and Paxlovid, if you've had Evushell, you come down with COVID because there are breakthrough infections. It's not 100%. Can you get Paxlovid if you've had Evushell?
Sure. Yeah. So there are breakthrough infections because it's not 100%. And as the variants shift away from Evushell being effective, I think we're going to get more breakthroughs. So then what do you do with somebody who's broken through? And Paxlovid is a very viable treatment. Molnupiravir is another treatment, although probably not as good as Paxlovid. And then if there's a monoclonal antibody that's present and effective, then that would be another way to go. And convalescent plasma is all options. With Paxlovid, there is something that's very important that people should know, is that if as part of their treatment for CLL or for another condition, they are on a drug such as tacrolimus, cyclosporin, or everolimus, or sirolimus, then they nothing is 100% medicine, but I would say close to 100% that they should not get Paxlovid. I recently saw a patient who had was on tacrolimus, and their level went from 2, which was a little bit on the low side, but fine, to 173, which is incredibly high, incredibly toxic of tacrolimus just by being exposed to Paxlovid.
And those drugs are used, those are immunosuppressive drugs for people with autoimmune complications, which are not uncommon. I was on cyclosporin for years for immune thrombocytopenic purpura, or low platelets, where my body was attacking that. And people get an anemia called autoimmune hemolytic anemia in CLL. So that these drugs are not unusual. But there's also interactions with ibrutinib and acalabrutinib. So you have to check with your pharmacist and with your oncologist, hematologist, before going on Paxlovid. That's less of an issue with remdesivir, but it's an IV drug. Is that still an effective option?
Yep. So just finishing up on that point that you said, primary care doctors are great. They know a lot, but they may not know that this problem with cyclosporin exists. So contacting your hematologist and even as another layer, working with a pharmacist to make sure that there aren't drug interactions with Paxlovid that are okay. Now, in terms of remdesivir has very few drug interactions. It is IV, however, and 3 days of remdesivir has been found to be effective in significantly reducing the risk of hospitalization for people with COVID. So that can be done. And then if somebody's sick enough to end up in the hospital, remdesivir can also be used there. It is IV. It can cause liver damage. So people that have abnormal liver function tests need to use it very cautiously or not to use it. But it's generally well tolerated.
There's a lot of good, but even more bad kind of in some of these slides that you're showing us about activity. But one of the highlights was bebtelovimab still seems to be extremely active. But I've also heard first that it's in short supply, and second that it's gone commercial. So can you talk to either of those points for us?
Sure. So all of the therapeutics for COVID were essentially paid for by the federal government, and then they gave them to the states. So bebtelovimab, a whole bunch of bebtelovimab was bought by the federal government and given to California or to Maryland. And when the funding for that ran out, then the federal government essentially turned to California, Maryland, whatever, said you're on your own, and California, Maryland, whatever, said to the patients you're on your own. So very soon, when the funding for that runs out, which I think maybe within days, then we're going to have a situation where either your insurance pays for it or you're asked to pay for it out of pocket.
And what about the availability of it? I heard that it was in short supply. Is that accurate, or is it just this sort of shift from government paying for it to insurance or the patient paying for it that's causing the issue?
No, it could be both. And some of the supply is because it's not being purchased anymore. Some of the supply is because the manufacturer is not making it in enough quantity to meet the demand.
Another thing that a lot of CLL patients get is replacement of their antibodies through immune globulins, intravenously or subcutaneously. And that's to prevent against general infections. Did those have a role to play in COVID, either prevention or treatment? The IV immune globulins, IVIG is the term that we use, or subcutaneous immune globulins. What's their role? What's their activity against COVID?
So increasingly, the answer is yes. So initially, when COVID first came on the scene, the IVIG or the subcutaneous immunoglobulin preparations didn't have any COVID antibody because the donors didn't have vaccination or COVID. As we now are in a situation where almost everybody has either had the infection or the vaccine or both, and in terms of adults, with that is the donor pool, and so the IVIG preparations do have now antibodies, oftentimes antibodies against COVID. Is it enough antibodies to provide protection? Probably not. I mean, it is going to provide some protection, but is it enough to eliminate the infection? Probably not. But somebody who is getting regular shots of immunoglobulin is probably getting some antibody against COVID in the mix.
So I think I know the answer to this. We're going to shift to some practical issues here. I've done everything. I've got all my shots, all my boosters, and I've got Evusheld aboard. So I can throw away my mask, right? I can, I don't have to socially distance. Is that correct? I'm being a little facetious here. Yeah.
So I'll take a step back saying your mask is only part of the different things that can be done to protect you. In and of itself, it contributes a little bit, but the cost is extremely low. Wearing a mask is not like taking cyclosporin in terms of a toxicity. And the more people that wear the mask, the better the protection. So how much protection do you get from going into the airport being the only guy that's wearing the mask? Some. Would it be better if everybody in the airport wore a mask in terms of your protection? Yes. But short of having Harry Potter's wand, I don't think that we can make that happen. So you can only control the things you can control. So you have to decide, how badly do I need to get on that plane? If your livelihood depends on it, then pretty badly. If it's for a vacation in Las Vegas, only you can decide how important that is for you. And then if you're going to do it, then wearing a mask is better than not wearing a mask. But unfortunately, it's not a full protection, because it's best when a lot of people wear a mask. N95 masks or a level of N95 masks are better than other ones, but also they're not the most convenient thing to wear. So you have the best mask is the one that you'll wear. So if you're not going to wear the N95 mask, then I say wear something that you will wear. If it's all the same to you, then wear the N95.
Yeah, we push pretty hard for an N95 and try to find one that's comfortable, that you feel good about, that you're comfortable to wear. They do provide a significant level of protection. I think they're even more important now when everybody else isn't wearing masks. So yeah, I would argue that. And when I've done, which is very few plane trips, I brought in a flexible straw and put it under my N95 to drink. I don't eat on the plane. I just drink. I don't eat at the airport. That's all that I do. So, so far so good, but I do have concerns. I don't think the mask is still, it's that Swiss cheese kind of approach that we've talked about. The more levels of protection you have, yeah. The vaccines, the Evusheld, the masking, the hand washing, all of this stuff, I think all adds up and makes it, helps you make those decisions. So what about if somebody, this is their dream? I was just talking to someone and he's put this trip off for years and years, and he's going to fly to Israel for 2 weeks. What about getting a prescription of Paxlovid before he goes, because he's a CLL patient, so he doesn't have to find a doctor in Israel? Or if you go to some countries, they don't have Paxlovid, So, and you have to get it within those 5 days. I know this is off label, but is this something we should be kind of elbowing our doctors for and say, hey, I know it's off label, but can we do this?
Yeah, so I call it the VIP approach, vial in pocket. It's it's hard for me to make a recommendation for something that's not authorized for that. But I will say, as a general term, I have many patients that I prescribe them that vial and pocket approach for a variety of different infections, particularly if they're going to a place where the access to world-class healthcare is can be spotty.
Yeah, I think it's a good idea again, but I wouldn't, something to talk with your doctor, and we can't really make recommendations that go against what the FDA and the CDC recommend. But it does make sense to me to have that protection. I like vial in pocket. I like that. So, what are you telling your patients about how to make these decisions about getting on a plane, going to a concert? And let me add another one that I think is a higher risk: going out for dinner with people, outdoors, indoors. What are you telling your patients? Because you specialize at Johns Hopkins with the immunocompromised. So I'm sure a lot of your patients are these people. They've gotten over an illness and they're saying, doctor, what can I do now?
So I would say that this virus is mostly transmitted through the air, and therefore, if the ventilation is good, then the risk for infection is transmission is much lower than if the ventilation is not good. So activities that I worry about is if, for example, they're going to go do a hot yoga or cold yoga, but in a closed, non-ventilated place. That worries me more than if they're going to go and have dinner al fresco in a where there's an outdoor patio. So those are so if I would have so first of all, take a step back. Life is for living. So I want people to be able to do as much as they can, but cautiously. So going out to dinner outdoors in a place where there's enough space between people, I think that would be something that I think people can do. In terms of going on a trip, more and more people are doing outdoor things like hiking or going to the Grand Canyon or to outdoor things. Those are probably better than going to an intimate music club. Probably bars are my lowest. The thing that I really don't want people to do is to go to a bar where people are really kind of closed in together. That's kind of how I would look at it.
And I think your thing, nothing is risk-free. So you have to say, what's the benefit? If it's a family wedding or something, you're going to take a higher risk for that than maybe something else. But nothing is ever risk-free. Let's talk a little bit about timing. So a couple timing questions. Should people wait to get the bivalent vaccines, or if they need a vaccine, should they get it now? Do you have any inside scoop on when the bivalents will be here?
So I don't have any inside scoop on it, but I would say when it's available, then that I would recommend it for immunocompromised people as a means of trying to prevent the infection.
We're coming up for a lot of people on the 6 months since their last shot for the Evusheld. So talk to us a little bit about the timing. In the timing guidelines that we've seen is that you're supposed to, if you've been vaccinated, you're supposed to wait 2 weeks to get Evusheld. But if you've gotten the Evusheld, then it's safe to get vaccinated at any point after that. There's no wait. But some people have been concerned that the Evusheld may diminish the efficacy of the vaccine, and the vaccine may gobble up some of the Evusheld because it's using up its antibodies. This is like theoretical talk, but it's not just among patients. It's physicians, I've said, who postulated this. So give us a sense of the timing of vaccinations and the Evusheld, and is there any concern about getting is there a best order, and is there any concern about a less than ideal order?
So for those things, I tend to follow what the ACIP recommends, because the work group for ACIP has actually looked at all the data that's come out from the companies and tries to and have been very thoughtful about it. So I would say whatever the ACIP is recommending in terms of the timing and the sequence of Evusheld versus the vaccine, that's what I would go with.
So let's, I have a lot more questions here, but let's just take a quick break from COVID and use your expertise as an infectious disease specialist. Monkeypox, should we be worried about that? Is immunocompromised? Because I've read that while most of the transmission is from intimate contact, direct skin on skin, and sexual contact, there is respiratory droplets, there's fomites like bed sheets and solid surfaces. The virus can last for a long time. If you're going to a hotel, if you're going somewhere, should I be worried about monkeypox? So that's my first question about monkeypox as a CLL patient.
Sure. So as you mentioned, monkeypox is generally transmitted through close contact, although it can also be transmitted through fomites. So it's not a zero risk, but I would say that the biggest risk is in people that are in close contact with somebody who has monkeypox. And right now, that's mostly men, and mostly men who have sex with men. But one expects that there will be a spillover into women and into some children and into men and women who do not have sex with men. So I think we expect that immune compromised patients in general are going to be at higher risk for having more severe disease. The disease is a skin disease for the most part, and it can look like a lot of other skin rashes. So that one of the problems that we're having is that doctors are not diagnosing it. Now, why are doctors not diagnosing it? One is an education issue, in that people have an idea from going online and seeing what monkeypox should look like. And in this monkeypox outbreak, it's actually looking like a lot of different things. It can look like chickenpox. It can look like a pimple. So it can be quite
yeah, I've heard it can look like herpes, like the herpes infection that people get in their genitals or around their mouth and stuff. I've heard that too. Yeah.
So there's a lot of underdiagnosis and undiagnosis that's happening, and then also doctors oftentimes don't know how to get the samples sent in the appropriate way. There's still a lot of barriers to getting it sent. So a busy doctor might say, well, it looks like herpes, I'll treat it as herpes, without going further.
Right. And just a quick question that came up here. ACIP, can you tell us what that is?
Sure, that's the Advisory Committee on Immunization Practices, and that's a group that consults with the CDC on immunizations.
Let me run through a couple vaccines. We've run through some vaccines here. Polio is a new concern. Is that a concern for CLL patients? And should I get the polio vaccine? And if so, which one?
So if one is to get the polio vaccine, it would be the inactivated polio vaccine, not the live virus, which I don't think is available in the U.S. Anyway. And I don't think that right now there's an indication for getting the polio vaccine in the general or in the immunocompromised population, but region by region that may change, so that if there's an outbreak in a specific community, then that would be something that the health authorities might reach out and tell people to get vaccinated. One of the reasons why there is polio outbreak is that there's been a movement questioning vaccines, and some of that movement has targeted religious minorities, so that the Orthodox religious minority in New York has been targeted by misinformation. There's a Muslim community in the Upper Midwest that was targeted with misinformation, and they because these communities sometimes are insular in that they don't have they don't tend to read the LA Times or the Washington Post. They read more of their own internal material. Then they're effective at being targeted by vaccine skeptics. And then, so that's on the one side. And on the other side, in some of the far right in the US has been leading this movement toward freedom. So freedom from the freedom to not get vaccines. And of course, I am all for freedom, but also freedom leavened with community responsibility. And so that's been a second target. And then the third target is historically been people that have been skeptical of Western medicine, that tend to be on the left side of the political spectrum, and that are skeptical of vaccines. So all those forces have come together to create pockets of inadequate vaccination. And for some diseases, you need to have 100% of people vaccinated in order to keep a disease away. And polio, measles, mumps have all been viruses that we've seen come back because of vaccine skepticism.
So there is a vaccine for monkeypox. It's a live, weakened, or attenuated vaccine, but it's non-replicating. If you were in a high-risk category, a man having sex with man, it's recommended that you get this if you've had high-risk exposure. Is it safe? Because we've been told that live vaccines are taboo for CLL patients.
Sure.
But this one seems to be an exception. Am I getting that right?
So you're pretty right that there's actually two vaccines that can be effective for monkeypox. One of them is Jynneos, which is an attenuated, non-replicating virus that is safe in immune-compromised patients. It's been tested in bone marrow transplant patients back around in the 2010s, and it was found to be safe. And how effective it is in a highly immunocompromised person, probably somewhat effective, but not nearly as effective as if they were not immune compromised, but still safe. There's another vaccine, which is a live virus vaccine that is called something like ACAM 2000. And that one is one that I would not recommend for a CLL patient unless there was an extreme situation, and that's a live virus that can replicate, and it's a vaccinia. Both of them are vaccinia, which is a related virus, but again, one of them can't replicate the Jynneos with a J, and one of them can replicate, which is the ACAM 2000. And so want to make sure to get the Jynneos one. Who should get the monkeypox vaccine? So somebody who's had suspected or proven contact with somebody who's had monkeypox, and whether that's occupational or whether that's through their sexual activity or other activity or living with somebody. And increasingly, I think that as the vaccine supply increases, then people that may have been in contact will also be given the vaccine. But right now, it's for definite contact and suspected contact.
Well, we're not going to get through everything, but I'm going to throw a couple of vaccine questions. Other vaccines, the flu shot, I'm sure you recommend that on an annual basis. Other vaccines that we should be thinking about as CLL patients?
Sure. So the flu shot is sort of like a no-brainer in that it absolutely should be done.
And we can get that with the COVID at the same time, right?
Yep. Exactly. Other vaccines that if somebody's not up on their pneumococcal shot, they should get it. Tetanus, diphtheria, pertussis, they should get one every 10 years. If they haven't had it, pertussis can be a particularly
Whooping
problematic.
cough.
Whooping cough. Yeah.
Yeah. And
And then
go ahead.
hepatitis B is somebody that everybody should be up on if they haven't, particularly because they're going to be in the setting where there's a lot of other patients, and hepatitis B is pretty easy to transmit. It's bloodborne, but it's pretty easy to transmit. It can even be through medical equipment by mistake. So hepatitis B is something that people should be up on.
Last vaccine question. Can you get, and I don't want to turn into an anti-vaxxer, but people worry there's a phenomenon in medicine called tachyphylaxis, where if you're exposed to things after a while, they lose their impact. Can we get too many shots? I've heard of people getting 10 COVID vaccines, just flying to the pharmacy and just getting shot after shot. Is there a point of diminishing returns? And if I've had no response to my first 4 vaccines, is there any reason to believe I should get the 5th? So, let me, there's some vaccine frustration there that I'm trying to address. Yeah.
Yeah. So at this point, the CDC is recommending the 5 vaccines, and I would say going beyond that, 6, 7, 8, 9. I don't know that I actually think that it's not going to be effective. Now, there is if somebody's had a vaccine and has had a response to it, and then just over time they ran out of antibody because they have CLL and they can't make new antibodies, then that's a person that potentially could benefit from getting another vaccine down the road. And that's also the same thing that happens with people like me, who I haven't been vaccinated after 6 months or a year, should probably get a booster for the COVID to get me back up. But if somebody's been vaccinated again and again, they're just getting no response at all, I say it's pretty unlikely that if you keep vaccinating them that they will get one.
Any final thoughts or things that you'd want to share with the CLL community, a vulnerable community? And we had some good news on the mortality rates being much, much lower. There's a paper that Dr. Nyman published out of Scandinavia, which showed a mortality rate in single digits, still too high, but way, way better than it was before with the new treatments and the new variants. But anything that you want to say to this community in summary?
Yeah, I would say that in August 2022, there's almost no reason why anybody in the U.S. should die of COVID, that the combination of the vaccines and therapies, outpatient therapies, and inpatient if needed, can all do a great job at controlling COVID, even in CLL patients, although that is, CLL people with CLL are still at higher risk for all the complications than people that are not. So if somebody thinks that they have COVID, thinks they have an exposure to COVID, it's a good time to reach out to your medical team to get advice. And if you feel like your medical team is not giving you good advice, then be an advocate for yourself and say, okay, ask the deeper questions. I had a situation about 3 or 4 months ago, patient with Waldenstrom's macroglobulinemia, not CLL, but somewhat of a similar disease, was seen in an emergency room for a hospital in our area with COVID, and called me before they went there, and I checked with them a few hours after they got to the emergency department, and they said, well, they're just going to manage my symptoms for COVID. And I said, no, that's the wrong answer. You need a monoclonal antibody, and only after demanding it, then they got the monoclonal antibody. So one needs to be an advocate for themselves, because the doctors that are taking care of them may not be tuned in like you guys are.
Well, our motto is smart patients get smart care. So we'll finish on that. But Doctor, this has been amazingly detailed and kind of a granular explanation of this. And I think people are going to get a lot out of it. Thank you for letting me kind of diverge a little bit and lean on your infectious disease expertise. But thanks so much, and thanks for your presentation, and thanks Robin for their presentation. Thank AstraZeneca, Beijing, Bristol-Myers Squibb, Janssen, and Pharmacyclics for making this possible through their support. Just to be aware that this post-event survey is critical to us. It helps us. We read every comment. And please forgive me. There was, I lost count, was well over 100 questions that came in. I mean, the counter only goes up to 99, and I was scrolling through them. So please forgive us if we didn't get to your questions. I tried to do my best here, but some of the answers, as you saw, aren't just yeses or nos. I mean, they're nuanced answers. But if you have a question, we'll try to respond to that. Please join us on October 26th. That's going to be noon our time in California, and at 3 p.m. on the East Coast. And that's going to be concerning about sequencing of care in CLL. So complete the survey, take a look at the, send us your questions. Be prepared for our next meeting. Thank you, everyone. The sequencing will be Dr. Susan O'Brien, and also somebody that a lot of you know, our own Terry Evans, who's had a 20+ year of dealing with CLL, and he'll be presenting the patient's perspective on this. I remind you that the CLL is invested in your long life. Please invest in the long life of the CLL Society by supporting our work. Thank you to everyone, and especially those of you who attended and worked hard to become smart patients. Thank you so much.